at EULAR 2025 Day 1, and I'm delighted to be joined by Professor Andrea Fava, Director of Lupus Translational Research Center at Johns Hopkins University in USA. I am Dr. Valentina Puccino, Assistant Professor and Consultant Immunorheumatologist at University of Pisa in Italy. I'm very enthusiastic to have you here, Andrea. First of all, congratulations for your work in the field of lupus nephritis.
Thank you.
And I know that you have found many other cell types beyond B cells that can contribute to damage and inflammation in lupus nephritis. Can you speak about that a little bit more?
Yeah, so today we're going to speak about other immune cells found in the kidney in lupus nephritis, and in particular myeloid cells. These are the cells that right after the antibodies and immune complexes enter the kidney, they are the kind of the first responders. They get into the glomeruli, they start the inflammation, they can induce injury, but then also they have additional roles in the tubal interstitium, which is the rest of the kidney. They are there and they can cause fibrosis. They can induce fibrosis and further damage. And so, yeah, we identified all these kinds of cells, and we are now exploring them further to better understand who they are, what they do, and how can we harness this information therapeutically.
Thanks. And again, still talking about these intraglomerular myeloid cells, do you think they can be targeted? So it's something that actually you expected to find?
Yeah, I think that we are already targeting them. When patients with lupus develop lupus nephritis, we usually start with high doses of glucocorticoids, like IV steroids and then prednisone, and that's probably the treatment that right now is targeting these cells very quickly to get rid of them because they are causing a lot of damage. But obviously the field is moving in a direction in which we want to have less and less use of steroids, and therefore understanding the identity and physiology of these cells perhaps can help us developing new treatment or repurposing the treatment that we have to target these cells and get rid for as much as we can of steroids.
So do you feel enthusiastic and hopeful about the targeting these cells and move towards clinical, so to move these new treatments into clinical practice?
I hope so, because again, I think that there is an initial wave of inflammation coming from these cells that could definitely be harnessed in terms of treatment. But then there is something that we are not really good at treating, which is these cells outside the glomeruli. The cells that are the macrophages in the tubal interstitium that are there, they are pro-resolving, pro-repair, pro-fibrotic. These are the cells that are stimulating the fibroblasts to cause scarring. And these cells may be there regardless of inflammation in the glomeruli. And we don't really know how to target those. And I think that that's where the money is, because the reason why we treat lupus nephritis is to prevent damage, to save kidneys, to improve kidney survival. And therefore, I'm confident that as we understand better how to modulate these cells, we will be able to introduce better treatment strategies.
Exciting. And I think it's very important also not to look at just one cell type, but also cellular interaction. And I think also macrophage and fibroblast interaction is now a hot topic.
Yes.
So last question for you.
Yeah.
So how do you feel about the future of patients with the lupus nephritis? So we will have actually new treatments to help these patients to feel better.
Yeah, I think that I'm very positive. I think that the future for patients with lupus nephritis is very bright. There will be a lot of innovations coming. I think that we already have more tools in terms of treatment. We have a huge pipeline of new treatments that are coming. I think there will be a revolution in the way that we define, diagnose, and monitor lupus nephritis with novel biomarkers. I think that in the next few years we will be able to detect lupus nephritis before injury happens, and for physician that means before the onset of proteinuria. And therefore, by capturing these patients very early, we can switch and shift the management strategy from treatment to prevention. And by all these different tools that we have to intervene, hopefully without steroids, without treatment that carry very high risk, in terms of side effects, I think that we're going to have a major leap forward in terms of improving outcomes.
Fantastic. All this is very exciting, and thank you, Andrea, for joining me today, and thank you everyone for listening, and see you around.
Thank you very much.